إن شاء الله هنبدأ اليوم مع ال AEC Academy course to prepare the urologist for the exam. That's barometric exam for Saudi Arabia and also for Gulf countries like Qatar, UAE, Oman, and Bahrain. All this included in this course. The course will focus mainly on the previous exam question and also will give you an idea about how the exam look like and typical exam question from previous trial of the candidate. I hope everything is clear and we can start now. This is exam preparation program. So during this program, we will focus on the exam question mainly. This course introduced by me, Dr. Ali Muhammad. This is the whole of the exam. This is the whole of the exam and how it look like. This is the barometric network. And this test is different for Saudi Arabia from other Gulf countries with number of the questions. The number of the question for Saudi Arabia, it's 200 question, and for Qatar, UAE, and Oman, it's 150 questions. This is the website for barometric exam for Gulf countries. This is a process during the registration for the exam. You will see it in the website of the barometric exam. And this is before you schedule your exam. If you have any question administration, please let me know. This is the barometric website that you would like to download it for Windows and also for Mac or OS. This is during your test space. Ensure your space comfort for environment required as also it is important to be your documentation. Like ID and also registration confirmation details, it must be ready. This is the demographic description for the exam and content of the exam, that the basic of urology is 5%, infectious inflammation is 10%, reproductive and sexual health is 8%, trauma and neurology 13%, urolithiasis and obstruction 15%, renal failure is 5%, adrenal neoplasia it is 10%, prostate condition is 11%, pediatric urology is 13%, patient safety is 5%, and professionalism and ethics is 5%, and the total of 100. This is for Saudi licensing examination for urologist. It is 200 MCQs in 4 hours. This is a note about the test specification and content have been reviewed and updated. Therefore, pass rates are adjusted accordingly. That means, yes, they bring for you a previous exam question from the previous trial of your colleague, but also that means you can find new questions. New question might be added to the exam. So the passing score is 65%. And this is for a registrar. That means junior registrar, and for senior registrar specialist is 17%. So above applies to eligabilities issue as of July 23, 2022 and beyond. That means including 2024. So all this is important for passing grade. That is for senior 70%, for junior is 67%. This is a urology biometric exam for Qatar, for UAE, for Oman. It is 150 MCQs in 3 hours, and the passing rate is 65%. We will see some of the previous exam questions that might appear to you in the exam. As a urologist, passing urology biometric exam is an essential step in your career. The exam is designed to test your knowledge, skill, and understanding of the urology-related concept. To succeed in this exam, you need to prepare thoroughly and have access to reliable study material. So during the course, we will help you by giving you full material that will help you to pass the exam, and also we will discuss with you step by step the content of the exam in lecture and also in exam solving questions. Here, this is a division of the material that we will provide it to you as a dry file during your study. You will cover all these important MCQs in very clear way. After finishing your course, you will be ready even for new question, but also it includes previous exam question. As I mentioned, even the last exam that said previously in the previous months, it will be added for you. This is a sample of the exam question. A 55-year-old woman who had sacral neuromodulation implant placed after 4 years ago. He declined efficiency despite several reprogramming sessions. A plain film X-ray is showing here. The next step to remove the lead and place new lead more medially. So we remove this lead and we will place new one more medially, because this plain film show that the lead is too lateral and too deep in the S3 foramens. The use of a curved style would allow placement of new lead S3 in more medial to lateral configuration, thereby allowing the maximum contact of electrode to the nerve. This is due to the nerve following a medial to lateral course. So the best way to remove the lead and also move it more medially, because the compression of the nerve, it is the main complaint for this patient. Revising the lead to place them deeper may create stimulation of the leg, and other unwanted effect might be appear. As for lead replacement is not recommended, a lateral lead placement would not allow optimal contact with nerve. It would be premature to remove the system and start botulinum toxin A injection. So furthermore, if ultimately utilizing the dose of botulinum toxin A used for OAB is 100 units. We have this question and we would like to know your answer regarding this question. The principal source of operator radiation exposure during endourological procedure is? Any one of you can raise your hand and answer the question. Just would like any one of you to answer this question. So the principal source of operator radiation exposure during urological procedure is C. Dr. Muntasir mentioned C. Zaid also C. So the answer is radiation scattered from the patient. Scattering of the primary beam from the patient is a primary source of radiation exposure to the operator during the urological procedures. For these reasons, maximizing the distance between the operator and the patient during fluoroscopy is a very effective method of reducing exposure. This explains why fluoroscopy source is best placed under the patient to minimize the radiation scatter to the operator. So we will put the source of the radiation during the fluoroscopy under the patient. This to minimize the radiation scatter. Radiation scatters from the other source, the primary radiation beam or leakage from the X-ray tube are less significant source of exposure. So we have this baby of 2 years old boy undergo left urethral reimplant. The preoperative VCUG and renal ultrasound are shown in the first two images. A routine postoperative ultrasound at the ones is shown in the last image. This is asymptomatic. The next step is we'll see the image here. So yes, this is the image of the patient. So follow up renal ultrasound in 2 months for this child. This is post-operative ultrasound. And as you see here, this is the patient have a reflux. Edema after urethral reimplantation is not uncommon 1 month after surgery. Observation is indicated as long as the patient is asymptomatic. The patient should remain on a prophylactic antibiotic and follow-up with ultrasound should be obtained 4 to 6 weeks after surgery, as we see in this scenario. So follow-up renal ultrasound in 2 months. If the hydronephrosis have not resolved at further follow-up, then a MAC3 LASIK serinogram should be completed to evaluate urethral obstruction. If the patient develop acute abdominal pain with nausea or vomiting, then more rapid MAC3 followed by BCN or an attempt at urethral stent placement may be considered. VCUG may be considered to evaluate whether the VUR is persistent after surgery, but it is not the correct next step to evaluate significant hydronephrosis. So this is the explanation. Here we have the grade of the reflex. Zygouriteric reflex is a grade 1 that into a non-dilated ureter. So a non-dilated ureter is grade 1. The grade 2 that's in the pelvis and calyceal with dilatation. Grade 3, therefore we have mild to moderate dilatation of the ureter, renal pelvis, calyceal system with the minimal bulging of the fornices. So minimal bulging of the fornices. And grade 4, that we have moderate urethral tortuosity and dilatation of the pelvic calyceal system. The grade 5, that we have gross dilatation of the ureter, pelvis and calyceal, and loss of the papillary impression and urethral tortuosity. This is a logarithm for antenatal hydronephrosis. As you see, we have ultrasound first. This is antenatal hydronephrosis, non-urgent, urgent, non-urgent. We repeat ultrasound 1 to 2 weeks postpartum. And if we have bilateral hydronephrosis, we will do MCUG. If the patient diagnosed with posterior valve, we will do resection. If the patient have vesicular reflex, we will do DEMS scan. If the patient have no posterior valve, no vesicular reflex, max 3 will be after 6 weeks. And here, if that the patient have unilateral hydronephrosis, we go with the same manner of the bilateral hydronephrosis. If the patient have unilateral hydronephrosis and ABD less than 15 millimeter, we will do MCUG of UTI occurred. That is for unilateral hydronephrosis. If the patient is normal, it is option to do MCUG. Ultrasound 3 to 3 months. If normal, we discharge the patient. Abnormal, we will check that is a patient to do another imaging to evaluate his situation. This is antenatal hydronephrosis, non-urgent, urgent. We will do immediate ultrasound after delivery. We have this question: 3 years old boy who underwent surgical correction for a high imperforated anus is unable to toilet trainee. VCUG reveal a large trabeculated bladder, grade 3 left VUR, and incomplete bladder empty. Ultrasound of the abdomen show 2 normal kidneys. The next step is, anyone? Here, Dr. Zahid mentioned that the answer is B. And of course, it's right that the spinal MRI is a correct choice for this baby. Spinal cord abnormalities, including tethered cord or thickened of or fatty film terminalis, and lipoma, have been noted in 20 to 15% of the patient with imperforated anus. So this is the key of this question. So this severity of the lesion is proportional to the severity of the rectal. In this case, the patient has high imperforated anus, so VCUG revealed trabeculation and VUR into 1 kidneys and incomplete bladder emptying, a collection of findings potentially due to neurological bladder dysfunction. The next step is spinal MRI scan. Due to ossification of the spine and spinal ultrasound cannot rule out tethered spinal cord after 3 months of life. So vasectomy, CIC, and the medication are premature at this point without UDS and a formal diagnosis of neurogenic bladder. We have this question of 12 months old boy has persistent right hydronephrosis with negative VCUG. The right kidney contributes 35% of the total renal function, and the T1, T2 is 30 minutes on max 3 renal scan after diuretic. So the next step is antibiotic prophylaxis. And any one of you? Who mentioned A? Okay. So the answer is E, as our colleague Dr. Zahid said, is a stubborn urethral reimplantation in this 12 months boy with persistent right hydronephrosis with negative VCUG. This child has primary obstruction megaureter associated with diminished renal function. Also, many children with primary obstruction A mega ureter will show gradual progression, improvement of degree of dilatation and rapid of washout with age. A decision to observe without intervention depend upon the renal function and the absence of symptoms. In the presence of significant impaired differential function less than 40, surgical intervention is indicated. Since the child is otherwise healthy and uninfected, primary reconstruction with stubborn urethral reimplantation is the method of choice. A temporal diversion by distal cutaneous ureterostomy or alternative creation of widely reflexing ureterovesical junction may be considered in the presence of extremely poor renal function. Yes. Or premature or young infant less than 6 to 8 months old. So the best option for this baby is tapering. We'll do tapered urethral reimplantation. So we have this 70-year-old man, history of hypospadias, has undergone multiple unsuccessful procedure for 8 centimeter benign urethral restriction. The treatment with the best chance of long-term success is so the answer for this question is perineal ureterostomy. Surgeon should be offered perineal ureterostomy to the patient with long segment urethral stricture who are unable to or unwilling to undergo urethroplasty. Urethral dilatation or ureterostomy will have no chance of long-term success in this man with several previous failed treatment along benign restriction. So the best way to do for him perineal ureterostomy. Self-dilatation will allow for procedure-free interval, but another surgical intervention is inevitable. Single-stage urethroplasty would not be appropriate in this man who lack healthy tissue in benign urethra. While two-stage urethroplasty is an option, success rates are approximately 80% compared to 90% with perineal ureterostomy. Success is typically defined by long-term patency, no need for CIC, and patient-reported outcome measures. So this is about background about the AEC. So we come to the next discussion topic here about renal tumor. We will go quickly through it. Many patients with renal tumor are found incidentally during the evaluation of the unrelated medical issues. Therefore, renal tumor are often asymptomatic. Symptoms might include flank pain, hematuria, weight loss, fever, and sweat. Signs might include flank mass, hypertension, new varicocele, especially rapid onset, and paraneoplastic syndrome. The classical triad include flank mass, hematuria, and flank pain. This is now rare because tumors are often detected incidentally at a low stage. So it is usually in patients with significant advanced disease, this triad. So this is the workup for the renal mass. if we have the patient have suspected renal mass by clinical or radiographic finding with tech history and examination that include blood pressure measurement and also imaging like renal ultrasound, CT, and MRI with gadolinium. All this is important in evaluating patient with renal mass. If the renal lesion is cystic, it might be simple cyst as Bosniak 1. If complex as cyst, it is Bosniak 2 to 4. Bosniak 1, no further workups. If Bosniak 2, it might be an option to do nothing about this, but the Bosniak 2F, here we will do surveillance for them by periodic ultrasound, CT, and MRI. If Bosniak 3 or 4, here that's it will go to evaluate for suspected malignancy. Suspected malignancy might be RCC or metastatic to the kidney. Here treatment is various. So suspected RCC is management is according to the grade of the RCC. If the mass is solid, this lesion is solid, malignancy suspected, as I mentioned, we evaluate it as malignancy. It might be secondaries to the kidney or primary in the kidney RCC. So if pseudo tumor is also solid mass, we will do DEMSA scan. DEMSA scan, if decrease DEMSA uptake or abnormal mass on CT MRI, here we evaluate it as malignancy. And if the uptake is normal in DEMSA scan, uptake parenchyma on CT or MRI, so pseudo tumor, no further evaluation. This is the Bosniak classification. This is Bosniak 1, no septa, as you see here. Bosniak 2, here we have 1 to 3 septa, it less than or equal 2 millimeter. Bosniak 2F, 1 or more septa, 1 or more than 3 septa, or many more than or equal 4 septa, less than or equal 2 millimeters. Bosniak 3, 1 or more than or equal 4 millimeters, thick or irregular septa. And Bosniak 4, it is 1 or more enhancing nodules. This is the Bosniak classification, the risk of malignancy. Bosniak 1 and 2, it is 0%. Bosniak 2F, it's 5% risk of malignancy. Compared with Bosniak 3, which is 50%. Bosniak 4, it is 90%. And we discuss all this previously. Evaluation of suspected renal mass should do physical examination that include blood pressure, skin examination, lymph node exam. Hypertension might be caused by paraneoplastic syndrome from RCC or juxtaglomerular tumor. This is a skin lesion seen in the patient with RCC. We have several skin lesions like ash leaf spot, and also skin adenoma sebums, ash leaf spot here as you see, and also we have shagreen patch, and we have periangular fibroma. All this is associated with RCC, especially in patients who have RCC with tuberous sclerosis. So this is associated syndrome with this skin lesion. And we have also other skin lesion is known as fibrofolliculomas, and this is a small white or flesh-colored babule on the face, neck, back, or upper trunk, and it's usually present in patients with RCC and BHD. Other skin lesion like what we call cutaneous leiomyoma, as you see here, the cutaneous leiomyoma is pink purple papule in the same location of the hair follicle, and it's usually associated with hereditary leiomyoma, RCC. This other skin lesion like papilloma, this is papilloma, and also we have trichomoniasis, which is actually a wart-like flesh-colored papule here, and typically in the face or dorsum of the hand and foot. This is a skin lesion associated with Pitton hamartoma syndrome, is known as Cowden syndrome. And keratosis is also a feature of the it indicate that the skill lesion indicate RCC. And here also we have glans macules. The glans macule is considered as also macular pigmentation of the glans, and it is also skill lesion associated with RCC, specifically patient with beaten hamartoma. This is all the skill lesions in details. Radiological imaging is also important if vena cava invasion is suspected. Obtain an abdominal and CT MRI. And obtain lab test. All lab test is important in patients with RCC, like blood urea, creatinine, alkaline phosphatase, liver function test, LDH, serum calcium, CBC, urine analysis. If urine show proteinuria, obtain quantitative measure of urine protein such as spot urine protein creatinine ratio, spot urine albumin creatinine ratio, 24-hour urine for protein. Assign a chronic kidney disease. That's for patients with renal function will do GFR. So consider pre-treatment referral to nephrologist, especially if the patients with pre-treatment GFR less than 45 ml. Measurement of differential renal function by renal scan. This might help you to guide you toward the correct therapy, especially when the contralateral kidney is small or appear to have decreased function based on CT or MRI nephrogram. Obtain chest X-ray or CT chest if the patient have abnormal chest X-ray, pulmonary symptoms, high risk of for metastasis, better to do for them CT instead of chest X-ray. But we will start by chest X-ray at first. Obtain a bone scan if the patient have bone pain, hypercalcemia, elevated alkaline phosphatase, bone fraction. They might be caused by, this bone fraction might be caused by metastasis or paraneoplastic syndrome. If neurological exam is abnormal or neurological symptoms are present, obtain brain MRI. So if the patient have CNS symptom, do MRI to look for metastasis, or if this lesion associated with von Hippel-Lindau syndrome, or if this lesion associated with tuberous sclerosis. And spine image might be also is performed if symptom or exam suggest spinal cord compression. In women at the risk of breast cancer, consider performing breast exam and mammogram. Breast cancer may metastasize to the kidney. Biopsy for the renal lesion might be indicated in some cases. Biopsy of the renal mass. Biopsy is not part of evaluation. It is not the standard part of the evaluation. It should be considered when there is suspicious that the renal lesion might be infectious, inflammatory, angiomyolipoma, lymphoma, or tumor metastasized to the kidney. A candidate for nephrectomy that choose to undergo surveillance, ablation, or embolization is an option to do a biopsy to confirm the diagnosis of RCC before systemic therapy in the patients with metastatic or metastasis that who is not a candidate for cytoreductive or palliative nephrectomy. In this case, the renal lesion or metastatic lesions might be biopsy. Renal biopsy techniques. So the technique, biopsy is performed percutaneous under CT or ultrasound guides using 16 to 18 gauge needles, so not more than this. The biopsy needle is advanced coaxial through the sheath to minimize the risk of the tumor seeding along the biopsy tract. So at least 2 to 3 core biopsy should be taken for each mass. Core biopsy is preferred over the fine needle aspiration, FNA, because core biopsy has higher diagnostic yield. This is the needle for the biopsy, and this is the coaxial sheath for the needle. This is the needle with sheath to protect the seeding of the cancer cell. Here we use the ultrasound to take the biopsy This is an office-based renal ultrasound under local anesthesia with needle pass through a probe to target the renal cortical neoplasm. As you see here, this is the kidney, and here the operator or surgeons take the biopsy. This is a ultrasound to assess the needle while passing to take the biopsy. Here, this is the needles which is reaching the lesion. As you see here, this is the TR regulatory lines, and this is the needle for the biopsy, 16 gauge biopsy device. Side effect of the renal mass biopsy: serious side effects occur in 1% of the cases, include bleeding, severe pain, pneumothorax, and severe infection. Tumor seeding along the biopsy. Tumor seeding is rare. Tumor seeding is more likely when the biopsy is done with needle more than 20 gauge. So here is also important to use coaxial sheaths. So without the coaxial sheaths, the seeding is also is increased or might happen. Biopsy of renal mass should use needle less than 20 gauge and coaxial sheaths to minimize the tumor seeding along the biopsy tract. The biopsy of cystic mass have high risk of spillage or seeding. The metastatic melanoma and renal angiomyolipoma (AML) stain positive for HMB, that's the human melanoma black antibodies 45. And here, if the biopsy of renal mass is stain positive for HMB 45, then it's usually either AML or melanoma. So this is first used for melanoma. The seeding might appear, Dr. Muntasir, to adjustment organs like intra-abdominal organ, retroperitoneal organ. All this, the seeding can occur in retroperitoneal space. Here you have question about the renal biopsy of RCC. Is contraindication as leading to seeding of the tumor to skin. We mentioned that is not contraindication, but we have mentioned the indication for the biopsy. Indication for the biopsy, you have many indication to do the biopsy. So regarding this indication, we do the appropriate method to take a biopsy. Here, this is a HMB 45:2 histology slides. It looks like this. It is brown in color, like this, with human melanoma, black antibodies positive, specifically in case of melanoma or renal angiomyolipoma. So we will speak about the type of the tumor, renal tumor. We have primary renal mass, that's the benign example. We have simple renal cyst. This is the most common benign renal masses, and papillary adenoma. This is the most common benign solid renal mass. And we have pseudotumor, angiomyolipoma, oncocytoma, juxtaglomerular tumors, and multiocular cystic nephroma and mesoblastic nephroma. All this considered as benign example for primary renal masses, but the most common benign renal cystic tumor, the renal cystic mass, sorry, is the most common benign renal mass is simple renal cyst, and the most common solid benign is papillary adenoma. The malignant example, we have renal cell carcinoma RCC. This is the most common primary renal cancer in adults. Wilms tumors, the most common primary renal cancer in the children, and clear cell sarcoma and rhabdoid tumor. All this is considered as malignant renal tumor. The most common in adults is RCC, and the most common in children, it is Wilms tumor. Regarding this point, the Wilms tumors usually occur in the age of 2 years to 6 years. This is a common age group. And we have metaplastic nephroma is considered also infantile malignancy, usually occur during first 6 months of life. This is known as mesoblastic nephroma. And other which is occur in less than 2 years is known as neuroblastoma. Neuroblastoma is occur in less than 2 years. So you must know this very important age group during the exam. Secondary renal tumors, the secondary metastasis to the kidney might be occur most commonly from the lymphoma, leukemia, and secondly from lung, breast, cervix, stomach is first, and colon, cervix, and the list is from melanoma as secondaries. Pseudo tumors. These appear to be solid renal mass on some image study, but are actually normal renal parenchyma. Examples that include column of cretins, fetal lobulations, and also tromery humps, hilar lips or ancus, nodular compensatory hypertrophy. All this is considered as feature of pseudotumor. So it is solid renal tumor on some image studies, but are actually they appear on some image studies, but are actually normal renal parenchyma with this characteristic. Following image study can help differentiate pseudotumor from true tumor. CT, MRI, DEMSA, renal scan. CT optimized to examine the kidneys. MRI optimized to examine the kidneys too, and DEMSA scan, this is to differentiate between pseudotumor and true tumor. On DEMSA scan, renal scan, pseudotumor have normal isotope uptake, whereas the true tumors have decreased isotope uptake. Here, this is 2 years boy have dysplastic kidneys with echogenic left renal pseudotumor. As you see here, this boy with dysplastic kidney and have this dysplastic kidney with echogenic left renal pseudotumor. We mentioned that the isotope on DEMSA scan is normal uptake compared with tumor, true tumor, decreased isotope uptake. And here this is technetium DEMSA scan for the tumor in the left lower pool of the kidney. This is a true tumor. This is a true tumor. So the uptake is decreased for this one. Dromedary hump, a focal bulk at the medial lateral kidney, sought to be from downward pressure from the spleen or liver during development. It is more common on the left. So it is normal compression in the kidney. This is dromedary hump due to this is splenic impression due to compression from the kidney during development, and this is in the ultrasound. It's come from this appearance. Here we have a relative frequency of renal neoplasm. Small solid renal mass are more likely to be benign than large renal masses. 20% of the solid mass less than 4 centimeters are benign, where only 8% of the mass more than 4 centimeters are benign. So solid mass are usually malignant. The most common solid renal mass in the adult is RCC. Here we have the frequency, relative frequency of solid primary renal tumor. We have clear cell is 65%, papillary is 10 to 15%, chromophobe RCCs is 5 to 10%, and unclassified RCC is 1 to 4%, collecting duct is less than 1%, oncocytoma is 7%, angiomyolipoma is 1 to 2%. All this when the all size are included. This is considered as the relative frequency, but the most common is clear cell. Clear cell is 65%. The second is papillary. Second is papillary is 10 to 15%. شكرا لكم على حسن الاستماع. Thank you very much. If you have any question, please let me know. شكرا.